Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Tracy, you probably know this, but headaches are really common. In fact, in the United States, over 15% of adults complain about a severe headache or migraines. Migraines, yeah. Migraines affect... Let's start over.
I like you guys.
See, it's going to be fun.
Right.
Go ahead.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Tracy, as you know, headaches are really common. In fact, in the United States, over 15% of adults complain of a severe headache or a migraine. And in fact, migraines affect some 40 million people in the United States.
Ugh. Headaches are twice as common among women than among men, and interestingly, headaches are more common in younger people than those aged 65 and older. Here to talk about headaches, including the latest treatments, is Mayo Clinic neurologist Dr. Beth Robertson. Welcome to the program.
Thank you for inviting me.
So let me ask you about your job. Do you spend all day, every day, seeing people who have headaches?
I do. So I have a background in both nerve and headaches, but I'm interested only in the nerves above the neck. So all day, every day, those are my patients.
And are most of these people do they have migraines or what
The
kind
strong
of headaches?
majority of our patients do have migraines, often very severe migraines that have been hard to treat with their local physicians. So they've had years of difficult to treat headaches before we see them.
You know, before we talk about migraines, tell us about the headaches that most of us get from time to time. The ordinary headache. Do you call them tension headaches? And why do we get
Common
those?
headaches.
Right. Common headaches.
Right.
Yeah.
So I think, so what most people refer to when they're talking about that ordinary or normal headache would be a tension headache. That's more of a mild, dull, pressure type sensation on both sides of the head, sometimes triggered by stress, sometimes not sleeping enough the night before. And those are often treated with over-the-counter medicines.
Which one's best?
So most patients prefer NSAIDs, non-steroidal anti-inflammatory medicines like ibuprofen or Aleve.
Okay.
But any over-the-counter pain medicine might be helpful.
Acetaminophen's okay too.
That's right.
Whatever works.
That's right. And most of the time, people are able to function with those. They take the medicine, they go about their day, and I never see them in clinic.
When my kids complain about headaches, or even for myself, I just say, drink some water. And that seems to help. Maybe it's just gives you a little bit of time. Do people get headaches because they don't drink enough water?
So dehydration can be a trigger for headaches, often a trigger for migraine headaches. And my son who struggles with migraine, I also tell him to drink some water as a first line. But it's less common to trigger the tension type headache.
I was surprised to learn that there are 40 million Americans. No wonder you're so busy. We're lucky we got you in the studio. 40 million Americans who have migraines, and it's 18% of women and 6% of men. Much more common in women. Any reason for that?
So I want to say, too, for those almost 40 million patients, there's only about 500 headache specialists. So we are quite busy. But as far as why women, so the brain doesn't like change, and migraine brains are particularly vulnerable to changes in sleep, changes in stress, and changes in hormones. So women have those cyclic changes in estrogen around their ovulation and menstrual cycles, and then around pregnancies, and as they get close to menopause, there's this roller coaster over their lives, and that tends to contribute to triggering the headache.
What can you do to fix or to help people who suffer from migraines?
So there are a number of treatment options, and we would divide treatments into acute treatments, so a treatment that you would take at the onset of the headache, and then a treatment that they might take every day to reduce the frequency or the severity of the headaches. Those are preventative medicines.
And you've got some new in both categories, right?
We do. Yeah, it's a very exciting time for migraine. It's really it's nice to be a headache practitioner these days because we have so many new options. Our classic options for the acute treatments have been, as I mentioned, sort of over-the-counter and then non-steroidal anti-inflammatory drugs. And then we've had triptans for many years now that we would use for patients. But more recently, we've had some newer classes. So we have something called a Gepant. This just came out. Ubrogepant is the first one that's been FDA approved. That came out over the holidays. and that is focused on a different pathway. So instead of our classic migraine paths that we're trying to address, now we're focused on something called the CGRP, or calcitonin gene-related peptide molecule.
Yeah,
so
try to remember that, Tracy.
Right. I know it's a long word, but CGRP, we've known for decades, has been involved in migraine. So we know that during a migraine, CGRP goes up. When you treat the migraine, CGRP comes down. And if you inject CGRP, it will cause a migraine. So we've wanted to figure out how to disrupt that CGRP pathway for quite some time. And the preventatives that we can talk about in a little bit, if you'd like, have been focused on that pathway. But in our acute medicines, this ubrogepant has been designed to block the receptor for CGRP. And it seems like this is able to bring down the headaches in a way similar to the triptans that we've been using for headache in the past, but maybe better tolerated and maybe a little safer for some of our patients. So our triptans were an issue for anybody with a heart attack or stroke because they constrict blood vessels. And this new class, this gepant class, does not constrict blood vessels.
All right, and the exciting thing also is those 3 new drugs approved in 2018 to prevent migraines. 3 different ones. Do they work?
Yes.
You said that
Not
a
in
little
every,
bit
well,
hesitantly.
because there are commercials that maybe are a bit misleading. No drug works in every patient.
Mm-hmm.
But yes, these are also trying to address that same CGRP pathway. So there are 3 what we call monoclonal antibodies that are out. So these are antibodies that are targeting, in 2 of the cases, they're targeting the CGRP protein, and one of them is targeting, again, the receptor, trying to interfere with that pain signal that we think is going on during migraine. And then there's another one that should come out later this year. And so these have been given in a monthly injection form. There's also a potential for an every 3-month injection form. And those, if people are taking them over time, about half of patients will have a 50% reduction in their headaches.
So that's pretty good.
It's pretty good.
Okay.
Good.
If someone has migraines, they find something that works, then does that efficacy wear away and they have to then move on to something else? Or if you find something that works, are you set?
So both can happen. Some patients do find that magic drug, maybe one that we've already been using for many years, and they do well for years. And then other patients may find that the effectiveness wears off over time and they require something else. And I don't want to mislead, these CGRP medicines are very glamorous, but we do have a lot of other weapons in our arsenal as well that can also help.
Such as?
So there's another new one that I really feel obligated to mention that's in the acute medicines category called lasmiditan. It also came out this year. It's a cousin of the triptans, but also does not constrict blood vessels. So again, it's about finding something that's safer for these patients that have really been untreated for a migraine population. And then we also use Botox injections quite regularly as a preventative with good success.
Counseling, also part of the treatment for patients with migraine.
So counseling like
behavioral therapy.
Behavioral therapy, sure. So many of our patients do have associated anxiety and depression, and maybe they started anxious and depressed, or maybe just being in pain all day, every day, which many of our patients are, has led to anxiety and depression. And the problem is that feeds back and that can worsen headache over time. So sometimes patients do require additional help addressing that, either with additional medicines for depression or with cognitive behavioral therapy, sometimes stress relieving activities, exercise, meditation, yoga, things to help address that.
Does acupuncture ever work?
Ever? Yes, absolutely. No question.
Yeah, sometimes? Okay.
Always? No.
All right, we don't want to let you go back to your desk and your patients until we talked about cluster headaches, because some people have said that they're even more painful than migraines.
So as far as we know, cluster is the most excruciating pain that we can experience. So from patients who have had both labor and cluster headache, it is worse than labor. It's worse than kidney stones. It is a severe 10 out of 10 pain that's around one eye, associated with watering of the eye, almost like you've cut an onion, just tearing, runny nose. And instead of going to sleep and trying to hide from the light and sound like our migraine patients do, patients with cluster will pace back and forth. They're agitated. They'll bang things against their head. I've had patients where they've asked someone to kick them in their head repeatedly because the pain was so severe. And then abruptly, after 15 minutes to 3 hours, it just comes back down.
Oh my gosh.
But recurs. So it may occur 8 times a day for weeks to months at a time. That's called a cluster cycle. And sometimes those cluster cycles may happen, once or twice a year, but may happen in the same months each year. So as that month approaches, the patients start panicking. Oh my gosh, my cluster cycle is going to come back. I don't know if I'm going to make it through it this time. And I have actually had 2 different patients try and commit suicide.
No. Do you have treatment for these kinds of headaches, I hope?
Yes. So we have a lot of treatments. We are significantly more aggressive with cluster headache, just trying to get them down as fast as possible. So we have acute medicines. The triptans, like we use for migraine, we'll use a faster one. So instead of taking the tablet and waiting for it to go through the food that they ate the day before or that day, we will give them an injection of a triptan, or sometimes a nasal spray, although that's not always fast enough. We will do oxygen. Sometimes 100% oxygen for about 20 minutes can reduce the pain. And then there's a new stimulator that can stimulate the vagus nerve, which is a nerve involved in some of the tearing. And
in your neck?
Yes. And so the stimulator there sometimes can help with the headache in the moment. And then we try and shorten the cycle. So we'll give them steroids, or we'll give them what we call nerve blocks. So we'll block the nerve in the back of the head. It's not intuitive that pain up here can be helped by blocking the nerve in the back, but it is. And that will be with a numbing agent and a steroid. That can bring the cycle down. And actually, one of the newer CGRP antibodies, one of them called Emgality, has been shown to help reduce the cycle as well. And then,
so a bit of a preventative.
That's right. So it may help, if the cycle would have been months long, maybe it brings it down to weeks long. And then if they're having frequent cycles, we'll try and put them on a more daily preventative to try and reduce the chance of that cycle. And that can be helpful. So I have patients that will show up the month before their cycles usually happen. We'll start them on a medicine called verapamil, which is a blood pressure medicine that's specifically very helpful in this cluster headache population. And sometimes we're able to bypass that seasonal cycle altogether. And they're so grateful when that happens.
We just have one more question.
Yeah.
The hangover headache. What do you recommend?
I don't see those a lot in clinic, but hangovers are multifactorial. So you have the alcohol toxins floating around actually triggering headache, and then you have the associated dehydration that needs to be addressed separately.
Drink some water.
That's right,
okay.
water. And then, alcohol interferes with the quality of sleep, the sleep architecture. So sleep deprivation can sometimes worsen the headache. So obviously you sleep it off, drink water, or maybe avoid the alcohol entirely.
Time machine.
I knew that was going to be the answer.
Always the answer.
All right, headaches and migraines, common problems and a source of disability for a lot of Americans. Now, fortunately, the treatments for migraines are better, and there are even some newer medications out there that will actually prevent migraines.
Absolutely.
Our thanks to neurologist Dr. Beth Robertson from the Mayo Clinic. Thanks so much, Dr.
Thank
Robertson.
you.